All right, here we are back with part 2 of chapter 46 in Patients with Special Challenges. We left off part 1. We were talking about some special devices and equipment that we commonly find these individuals with special challenges may be using. Not necessarily the things that we need to be overall familiar with, but just aware of the fact that they may have some very unique equipment that is basically helping to sustain their existence. And so we'll pick up there kind of where we left off, talking about those different devices. There's lots of different kinds of long-term ventilators out there that may be used with patients that have spinal cord injuries or other types of conditions. They're also used in patients with neuromuscular diseases and patients with lung injuries that may require some long-term ventilatory support. These things are way smaller than what they once used to be. They used to be very large machines, very cumbersome machines, very difficult to transport when you had to transport somebody on one of these. Now they're much smaller, much more portable, much easier to use, which is great for the patients because they're able to actually, maybe get outside of the room where they're being cared for at home. So the primary assessment should include checking the ventilator, making sure that it's working right. If the ventilator doesn't seem to be working well, work with the patient and the caregiver to try to adjust the settings to see if it can be corrected. Make sure you understand the critical effects of any ventilatory changes before you make any of those adjustments. So make sure you understand what you're doing and you understand what that device does before you make any of those changes. If absolutely necessary, you can go ahead and completely disconnect the ventilator and use a BVM or switch to your transport ventilator that you may have. If that's necessary, you can do that. A CPAP and a BiPAP device can also provide non-invasive options for oxygenation and ventilatory support. So if you don't have a transport ventilator, maybe one of those devices might work as well. There's also a type of ventilator that's a diaphragm or phrenic nerve stimulator that can help some patients breathe without the actual ventilator. What these do is they stimulate the breathing nerve, then it makes them to breathe. But if they fail, we can provide ventilation using conventional methods such as bag valve mask. Be aware that asynchrony may happen between the mechanical ventilations and the patient's own breathing if the device is still active during bag mask ventilation or during ventilatory assistance. So it's something you got to watch out for and make sure that that's not going to be an issue. Ventricular assisted devices are much more common today and are used to kind of create a life-saving bridge for patients that are in severe heart failure. EMS has limited options for intervention in the field with these devices. You may be able to help by checking and correcting issues with the battery or power supply, but mainly what you're going to do is you're going to focus on supportive care and arranging for medical transport. The goal with these is to get them to a facility that can manage that particular device and make repairs or corrections or those kinds of things with it. The older devices used to come with a manual compression device or a manual device to make it work as kind of a backup. Typically, it's a battery-related problem, but we don't typically do chest compressions on patients with these because we would dislodge the device, and oftentimes chest compressions are not quite as effective on these patients either. Apnea monitors are often used with infants at high risk for SIDS or other apnea-related conditions, as well as for those that are diagnosed with sleep apnea. The type of monitor is going to vary depending on the reason it's being used. Infant monitors typically track EKG, breathing, using transthoracic electrical impedance. So a little bit of magic sensory voodoo kind of thing. These monitors can detect central apnea, but might miss apnea due to airway obstruction. So they're not really designed to catch it for airway obstructions. Many home monitors don't display waveforms or numeric values, so they're not really going to tell you much or give you a lot of insight. They're just designed to alarm. Now they may record all those parameters, but they may just only make an alarm noise. Always use ALS resuscitation equipment when you're taking care of patients with apnea monitors, so you have to switch them out to your equipment. These devices, these long-term vascular access devices, these are commonly used when IV access is difficult or nearly impossible, and when certain medications need to be given over time. Common reasons for these are going to include things like chemotherapy, vasopressor, long-term antibiotics, dialysis, frequent blood draws, and those medications that are just generally irritating to vessels. Many of these lines are maintained with heparin to prevent clotting. So in order to use these, you must have very specific training and approval from your medical director. More than likely, you'll have a protocol in place if you're transporting a lot of patients with these indwelling devices. But realize you can't just randomly use one of them, because there is a very specific way that they have to be done, and it is a surgical procedure to remove and replace them. Always contact medical control before using them. Before using the line, you got to draw some blood up to about 10 mils and remove any of the heparin that's in there. The heparin's only there to keep it from clotting. This should be done before flushing, giving any kind of meds, or starting any kind of infusions. And of course, strict sterile technique is essential with these, and proper port cleaning so that we can eliminate blood infections. Remember, this is going directly into a vein, so any infection in this is going to, can quickly lead to sepsis. We're already talking about a patient that is potentially immunocompromised anyway, so we want to take extra precautions. PICC lines or peripherally inserted central catheters. These are a long IV catheter placed in the arm. It follows the vein into the superior vena cava and may stay in place for up to a year. They're smaller in diameter but longer in length, and this may slow rapid infusion, so it's going to be hard to give a whole lot of fluids through. These may or may not be flushed with heparin. It all just depends. Midline catheters are typically placed in the upper arm. They're a little bit shorter than a traditional PICC, but they're still much longer than a regular IV. They're better for those irritating medications that can cause the vein to get really irritated and inflamed, and they typically do contain heparin. Then they even have the double or triple lumen central catheters. They're placed near large central veins. They're common in sites like femoral, internal jugular, and even subclavian, usually placed in hospitals, but remain after they're discharged, and they usually contain heparin when they're not being used as well. And then we've got some name brands, the Hickman, the Paramedic, the Goshnog catheters. These are tunneled under the skin into the superior vena cava, usually contain heparin and resemble a dialysis kind of catheter. The ports may be red, blue, and green. They're typically color-coded. They don't use clamps or hemostats on the catheters either, so they're not plugged off that way. Then we have these things called implanted ports, or a portacath. They're completely under the skin and tunneled into the central vein, about the size of 1 or 2 hazelnuts, so they're fairly small. Flat and slightly rounded at the top with a palatable edge. They're accessed with a 90-degree needle that has plastic wings, and these contain heparin when they're not in use either. There are many of these that we're talking about. We're not going to have the tools and equipment on our truck to be able to access, so we typically don't mess with them. Dialysis catheters, they're usually placed in the neck or the groin. They're very thick-walled, and they're designed for high-volume fluids, or high-volume units, typically blood. Often only accessed by dialysis or specially trained nurses. These are stored with high-dose heparin, and these may cause significant bleeding if they're not capped or clamped properly. And of course, accessing these devices is considered outside of the scope of practice for a paramedic in most places, unless you've had specialty training, which I'm telling you right now, none of you have. What I'm getting at is if you go out there and you take a job that's going to require you to use these types of devices, you're going to take some specialty training for how, when, where, and under what circumstances to use or access these devices. Medication infusion pumps. These infuse medications, and they may include inotropic drugs. It could be IV nutrition, chemotherapy, antibiotics, or even a whole host of other substances. A patient's condition might still get worse even if the pump is working properly, so it's no guarantee the medication is going to fix everything. Keep the infusion going and contact medical control. Usually there's no need to adjust the pump or medication rate. We typically will leave that alone. The problem is with these long-term vascular devices is they just simply don't last forever. They get clogged easily with blood clots, and they may even become infected. Mechanical failure or being pulled out can happen as well. So you may need to start an IV and realize that there's a reason why they have an indwelling catheter or an implanted IV catheter. It's because they're typically going to be a hard stick. But to troubleshoot the infusion, you can try a few things. Maybe try to plug it into the ambulance's power inverter. It could be a power issue. Switch to a backup pump if there's one available. And then you may just have to calculate and run the medication by gravity drip if needed, if you don't have a pump that you can switch over to. And of course, don't hesitate to ask the patient if they know of any workarounds or helpful tips that might get it going again and get things working. Feeding tubes are a soft, flexible tube that can either be placed through the mouth or nose or directly through the skin into the stomach or the small intestine. These tubes deliver food and fluid straight to the digestive system so the patient doesn't need to chew or swallow. This can help lower the chance of aspiration, though that's not typically why they're placed. Tubes that can go into the stomach include the nasogastric tube and the orogastric tube. Either one of those are devices that we can be trained to place in patients. It's a relatively simple procedure. Other types of feeding tubes are the nasoduodenal. It's going to run from the nose to the duodenum. The nasal jejunal runs from the nose to the jejunum. And the gastrostomy tube is surgically placed to the skin into the stomach. The junostomy, of course, as you guessed, it's going to be surgically placed in the jejunum. And then we have PEG and PEG tubes. These are surgically placed into the stomach, or PEG, gastric, is what the G stands for, or jejunum, which is what the J stands for. And these are typically placed using an endoscope. You probably won't need to fix or try to fix feeding tube problems often, but sometimes during transport some things can happen. So keep an eye out for pump problems, signs of vomiting, or even aspiration. Always keep the patient's head elevated during and after feeding, and if there's a problem, stop the feeding right away. Try flushing the tube with tap water to help prevent or clear out any clogs. Oftentimes what you see with feeding tube patients that can happen is they get a bowel obstruction that's kind of unknown to everybody because of the level of responsiveness of the patient, and food is still going in, but now it's backing up and it starts coming out, through the top. So sometimes that happens with feeding tubes. Colostomy is a surgical procedure that brings part of the large intestine out through a stoma. Colostomy bag then collects all the stool and intestinal fluids for disposal. Sometimes the bag can separate from the abdominal wall and may need to be replaced or temporarily taped back in place. If the bag becomes full, the patient may need help removing it and emptying it. Of course, gas can build up in the bag during longer transport, so it may need to be released. You may need to release the gas or burp it periodically. Urinary diversion is also sometimes needed for conditions like bladder cancer, congenital abnormalities, or major urinary obstructions. A urostomy diverts part of the urinary system through a stoma, allowing urine to drain into a plastic bag. Care for urostomy is similar to that of a colostomy and may include the occasional emptying, reinforcement, or reattachment of the bag. Catheters are used when patients are unable to urinate on their own. Some catheters stay in place like Foley catheters, while others are used temporarily like straight catheters. Paramedics don't usually perform catheterization in the pre-hospital setting, but you can see details of how to place a urinary catheter in skill drills 46.2 and 46.3. This is a skill that is performed quite routinely by paramedics, but typically during our shorter transport times, it's not something that's necessary. So many paramedics are not familiar or not well versed with this skill. Of course, we've talked about this one quite a bit. Of course, dialysis is a treatment used when the kidneys are failing or have failed. Kidney failure often occurs alongside chronic health conditions. As the kidneys stop working properly, fluids, electrolytes, and toxins begin to build up in the body. If not treated, of course, this buildup will be fatal. Serious late signs of kidney failure are going to include things like coma, cardiac dysrhythmias, circulatory overload, all of which are going to obviously need immediate attention. Hemodialysis, of course, and peritoneal dialysis can be done in a hospital, a dialysis clinic, or at home. Oftentimes they're done in a dialysis clinic. There's not a whole lot of hospitals in Oklahoma that have inpatient dialysis, but there's a few. So those patients that are on dialysis that need a hospital stay often wind up at one of those facilities so that they can continue their dialysis treatments irrespective of whatever other treatments they're getting. Complications during and after dialysis can include major fluid and electrolyte imbalances, hypovolemia, fluid overload, and infection. There could be even fistula-related issues that can sometimes be serious and may involve life-threatening bleeding if they become damaged, as well as even a thrombosis or a narrowing of the vessel. Be especially cautious when giving IV fluids to dialysis patients, as even a small volume can cause fluid overload. Always monitor IV fluids closely and adjust based on how the patient responds. Patients with kidney failure often have electrolyte issues, particularly high potassium levels. Avoid medications that can raise potassium levels, such as acetylcholine, digoxin, and other beta blockers. Dialysis fistulas are delicate and prone to clots and infections, so handle them with care. Of course, we're always going to make sure that when we're taking a blood pressure reading, we're going to not use an arm that has a fistula in it. And we're also not going to start an IV or do blood draws on that arm. Generally speaking, we're going to leave it alone and not mess with it so we don't risk damaging that because they're so delicate. If you respond to an emergency at a dialysis center, first find out if the patient has already completed treatment or if they're still receiving it. If it's still in progress, a large amount of the patient's blood may be inside the machine still. So always work closely with the dialysis center staff to safely disconnect the patient if treatment is ongoing. So oftentimes after surgery, there can be different drains or devices may be placed to support the wound healing and closure. Wound drains help prevent fluid buildup and allow for monitoring the fluid's volume, appearance, and composition. Some devices may apply mechanical forces to stabilize the surgical area and promote proper healing. To get into all of the ones that are possible would be a laundry list of things that, of all these devices that they could be. The thing to remember is we shouldn't manipulate drains and devices. Interfering with these devices can cause serious problems like bleeding, infection, or the need for more surgery. If you need further instructions, reach out to medical control and find out more information about what the particular thing is that you're dealing with. Paramedics should also avoid adjusting orthotic devices, prosthetic limbs and braces, and those kinds of things as well. We should avoid doing that and leave that to the professionals to do. Some patients have an implanted hydrocephalus shunt, and they get these placed when there's too much cerebral spinal fluid around the brain. These can be caused by either producing too much fluid or not absorbing enough. The excess fluid then raises pressure inside of the skull, causing symptoms like headaches, vision problems, unsteady walking, nausea, vomiting, seizures, and changes in mental status. In babies and young children, hydrocephalus can actually enlarge the soft skull without affecting their facial features. Treatment, of course, is going to involve surgically placing a shunt to drain the extra fluid from the central nervous system. The shunt has three parts. It's an inflow. You have an inflow part of the catheter that's usually placed in the brain, the ventricle of the brain, and connected to a valve. And this valve controls fluid flow with a fixed or adjustable pressure, and an outflow catheter often placed in the peritoneal cavity. Patients often show significant clinical improvement after their cerebral spinal fluid shunt is placed. Patients and caregivers need to watch for complications with these shunts, especially soon after surgery. They often require periodic adjustments as children grow and their bodies change, and even in adults until that the happy medium of where that needs to be adjusted is found. Sometimes it requires some return visits, and it may result in an EMS call or two. Signs of increased intracranial pressure may indicate an infection, valve problems, or damage to the catheter itself. If the patient has headaches, vision issues, seizures, or altered mental status, suspect that their shunt is malfunctioning and try to make every attempt to transport them to the facility that initially placed that so that they can receive the care from their same physician. All right, so there's also a lot of medical technology that we wind up having to truck along with us and use in these inter-facility transports. Some of it's pretty common to EMS, especially in the critical care setting, and maybe even in the flight setting. Others of it are a little less common and a little more specialized. But of course, make sure that when you're dealing with these devices and all that kind of stuff, that you follow your state EMS rules and your medical director's guidelines and know which procedures, medications, and all that stuff that you can use and utilize during those interfacility transports. Interfacility transports is a big part of what we do. So we need to be prepared for that and be prepared to have a quick crash course on some new devices. Sometimes is the way it works. These skills and devices are common when working with air medical teams and ground critical care transport, as I've mentioned. But sometimes we're transporting a patient, say they're on an IV pump or multiple IV pumps. It's important that you understand how the pump works so that you can fix issues with it along the way. So don't be afraid to ask questions and get a quick crash course on how it works. Basic hemodynamic monitoring is going to include checking blood pressures, pulse rates, strength, urine output over time, skin temperatures, and end-tidal CO2, as well as mental status. So we want to make sure that we're monitoring all of those things as those devices are doing their things. So patients that require invasive hemodynamic monitoring is when doctors need detailed information about how well the heart, circulation are working, or to guide fluid treatment carefully. This monitoring may continue while medications are being given and during care after critical illness, trauma, or even major surgery. Invasive monitoring tracks things like continuous arterial blood pressures, central venous or right arterial blood pressures, pulmonary arterial pressure, pressures in the left atrium and ventricle, and vascular resistance in the body and lungs. So they're going to track a lot of things. Monitoring involves placing different types of catheters into various parts of the cardiovascular system. They can be in arteries, they can be in central veins, and they can also be in different chambers of the heart. These catheters connect to special tubing, which is usually filled with normal saline or some sort of heparinized solution. The solution is kept in a pressure bag to prevent blood from flowing out of the catheter and tubing. The tubing then attaches to a transducer that turns the fluid pressure changes into electrical signals, and the monitor reads those signals and displays them as a waveform and in numerical values. These invasive monitors help to identify signs of impending heart failure. It guides fluid resuscitation efforts. It can show how well CPR compressions are working. It helps distinguish between different types of shock, and it can even provide valuable information for managing some very high-risk patients. Arterial pressure monitoring uses arterial lines to track blood pressure continuously. These arterial lines also provide easy access for frequent blood tests or arterial blood gas sampling. Of course, there are some issues that's going to require frequent blood tests, some conditions that may result in the need for frequent blood tests, and those are things like sepsis, respiratory failure, DKA, and even silicate overdoses. I can't even say it. Larger arterial sheaths may be placed during cardiac catheterization. These sheaths are often inserted into the femoral artery. Sometimes they're left in place after that cardiac catheterization if the patient needs to transfer to another hospital for another invasive procedure that can reuse that. But patients should stay supine with their legs straight during and for quite some time after that sheath has been placed. Bleeding from a displaced arterial sheath or catheter can be life-threatening, so it's important to use extreme caution when transporting these patients, and they're going to require continuous monitoring of that sheath to make sure it hasn't dislodged or begin bleeding or anything like that. Not just externally bleeding, internally bleeding as well. Intra-aortic balloon pumps are used to reduce cardiac workload and improve blood flow in patients with cardiogenic shock. These are also used for patients with structural heart abnormalities. And of course, patients who have had myocardial infarction may benefit from intra-aortic balloon pumps. These pumps are used after cardiac surgery to help support heart function. An intra-aortic balloon pump consists of a relatively large machine. They have connective tubing and monitoring cables. They use a balloon catheter which is inserted through the femoral artery into the aorta. And this moving the patient and the machine requires careful planning and coordination, so it's quite an endeavor. Leg movement where the catheter is placed should be prevented by using a knee immobilizer or tucking in a sheet that kind of keeps that leg still. Then how these things work is the balloon inflates and deflates at precise times during the cardiac cycle. It inflates during diastolic, pushing the blood forward into the systemic circulation, and then it actively deflates during systolic, creating a brief vacuum that reduces the cardiac afterload. This process decreases a myocardial oxygen demand, and it reduces overall cardiac workload. It also improves systemic circulation. These machines are really bulky, and as mentioned before, they can be challenging to move and secure in an ambulance, so careful planning and thought needs to go into this. Most critical care transport vehicles are kind of designed with these balloon pumps in mind, so it's a little bit less of an issue. We also have ICP monitors and drains that may be placed in patients with an intracranial hemorrhage. It's also used for patients with severe head trauma. Patients maybe who have undergone neurosurgery may have an ICP monitor and or drain, maybe both in place. These devices allow for interior monitoring of intracranial pressure. They enable evaluation and the appearance of the cerebral spinal fluid so they can continuously monitor that. They allow for drainage of cerebral spinal fluid to help kind of maintain and lower the intracranial pressure. It's similar to a form of hemodynamic monitoring, except for it's in the brain instead of the vascular system. The transducer of the drainage system is usually aligned at the same height as the patient's ear. This alignment can be difficult to maintain in a really crowded ambulance, so it can be tough working around these. And of course, proper positioning of the drain is essential for these things to function properly. Improper placement can cause large volumes of cerebral spinal fluid to quickly enter or leave the patient's nervous system, which either way, too high or too low of intracranial pressure is going to cause us problems. So then we have these Doppler devices that use ultrasound waves to detect heartbeats, blood flow, and those kinds of things when palpitation and auscultation are ineffective. These ultrasound waves are converted into sound that confirms the underlying movements. They are used to detect and calculate fetal heartbeats in pregnant mothers. They help detect pulses in compromised extremities. They can obtain blood pressure or pulses that are too weak to feel by palpation. To use a Doppler device, place the water-based gel between the probe and the patient's skin over the target area, and then slowly move the probe until you detect the underlying flow or movement that you're looking for. Ultrasonography can detect heart movement during pulseless electrical activity. It can detect pneumothorax, it can manage fluid resuscitation, and assist in locating veins that are difficult to palpate. All right, so I think this might be the last topic that we talk about, this cognitive sensory communication impairments that we may run into. I could be wrong, there may be another topic, so don't quote me on that. We'll see though. Developmental disability refers to a diverse group of conditions caused by physical learning, language, or behavioral impairments. These impairments typically show up during childhood, and they usually continue throughout a person's lifetime. Developmental disabilities negatively affect communication. They impact movement, they reduce the ability to care for oneself, and they affect the prospect for employment. Some conditions, like autism, have uncertain causes for what makes them happen. Developmental delay occurs when an infant or child does not reach specific developmental milestones by an expected time frame. It can affect gross and fine motor skills such as crawling, walking, and hand-eye coordination. It can impact cognitive skills like reaching, understanding object permanence, and problem solving. It may delay social skills, including interacting with others and forming relationships. It can also affect language milestones such as talking, listening, and comprehending. Signs of developmental problems may appear in one area or across multiple areas. Delays are linked to many causes of developmental disabilities such as Down syndrome and autism. Depending on the cause, delays may persist into adulthood or resolve as medical or social situations improve. Early intervention is important and can help children catch up on missed milestones. Cues from the patient and caregiver can help guide the best way to interact and communicate, and patients may regress to a lower developmental level after a stressful event, illness, or injury. They may need extra time during assessment, procedures, and preparation for transport. Down syndrome is an inherited genetic disorder that causes developmental delay. It leads to cognitive impairment. It's characterized by a pattern of unusual physical features. These features include a flattened face and nose, a short neck is common, the eyes often have an upward slant, the tongue may protrude, and there's usually a single crease across the palm of the hand. Down syndrome is also known as trisomy 21. It occurs when an extra chromosome attaches to the 21st pair, creating a third chromosome, 21. Risk factors include having a sibling or a mother with Down syndrome, or maternal age at the time of conception also increases the risk. Chromosomal changes in Down syndrome may cause structural heart defects. They can lead to seizures. Many gastrointestinal problems may occur. Speech alterations are common. Hearing loss may be present. Other abnormalities can also arise. Individuals with Down syndrome may have a shorter life expectancy as well. Cognitive deficits may range from barely noticeable to profound impairment. Some may function relatively independently, while others may require constant help with basic tasks. Intellectual disability is a cognitive disorder that appears during childhood and includes a lack of adaptive behaviors. It affects the ability to live and function independently. It also impacts the ability to interact successfully with others. Diagnosing intellectual disability requires deficits in general mental abilities and adaptive functioning. These deficits must be present before the patient turns 18 years old. The clinical presentation and severity of symptoms typically vary widely. Autism and autism spectrum disorders involve developmental delay and are marked by difficulties in social interaction. They include repetitive behaviors. They cause challenges with both verbal and nonverbal communications. Diagnosis rates have increased in the United States, possibly due to better awareness and screening or an actual rise in occurrence. Symptoms may vary widely and can affect communication, social interaction, sensory processing, and the ability to shift attention, as well as the ability to just play. Some patients may remain completely nonverbal throughout their lives or during stressful periods. Developmental regression without another clear cause should be a rise for concern. Cognitive function in autism varies significantly. Some individuals have impaired cognitive function that meets the criteria for intellectual disability. Others have highly advanced skills in areas like mathematics, puzzles, memory, or art. When treating patients with autism, be very careful when communicating or initiating physical contact. Patients may become frightened or show aggressive behavior due to commotion or excessive stimuli. Physical contact should be preceded by clear explanation. It should be done from distal to proximal. Questions should be repeated in different ways to get consensual responses. And patients may show minimal reaction to pain or extreme discomfort from minor contact or injuries. Be sure to include caregivers during your assessment, treatment, and transport of these patients because it can be very helpful. Patients with conversation disorder may show facial or focal neurological symptoms caused by stress, like blindness, paralysis, or impaired speech. These symptoms are not voluntary and the patient is not faking them. Diagnosis and treatment are beyond the scope of EMS personnel, so if conversion disorder is suspected, maintain a professional demeanor. Continue to assess for other possible causes as well as other signs and symptoms. Hearing loss is the third most common chronic physical condition in the United States. It affects nearly half of the people over the age of 60. Hearing loss can hinder communication, it can limit social interaction, and it may interfere with infant development. It can make many safety and warning devices ineffective. Hearing loss can be congenital or it can be acquired. Genetic factors cause about 50 to 60% of congenital hearing losses in children, and about 25% of congenital hearing loss is due to environmental factors like maternal infection, RH incompatibility, hypoxia, maternal diabetes, and pregnancy-induced hypertension. Most acquired hearing loss results from excessive exposure to loud noise. Other causes include infections like otitis media and viral infections. Tumors such as acoustic neuroma can cause hearing loss as well. Many medications have ototoxic effects that can contribute to hearing loss. And of course, diseases like Merian-Eyre disease can also lead to hearing loss. The degenerative aging process can have an effect on hearing as well. Conductive hearing loss occurs when sound cannot travel from the outer ear to the inner ear. Sensorineural hearing loss happens when the tiny hairs of the ear fail to take up sound or nerve impulses are not properly conducted. Hearing loss can be one type or a combination of both conductive and sensorineural. Central auditory processing disorder involves difficulty interpreting speech when there's background noise. Auditory neuropathy or auditory dyssynchrony means that the ear functions normally, but the brain's auditory centers are not properly stimulated. This condition is linked to prematurity, congenital abnormalities, or other neurological conditions. Use sign language or written words to communicate with patients in these conditions. For those with minimal or partial hearing loss, slow, deliberate, and repetitive speech can help improve communication. Of course, this is just a picture of some common sign language signs and terms that related to illness and injury. Like with any kind of language and learning any kind of new language, it's repetition and practice that's going to make you better at being able to communicate and sign with your patients. But I'm going to warn you, as someone who does know a little bit of sign language, not very much, if you start signing to a patient that knows how to sign, you better be ready, because they're going to sign back, and you're probably not going to be able to keep up if you're just a passive sign language kind of person. It's because they're going to go fast. I mean, this is how they speak. So they're not going to go slowly so you can keep up. So be prepared with a pen and paper to communicate with them a little bit more clearly when they start using sign language. Of course, hearing aids can help improve the hearing and listening ability. There are some that are behind the ear that have that all parts are contained in a little plastic case that sits behind the ear. And then there's some that sit completely in the ear canal and are almost completely hidden. The in the ear hearing aids have all parts in a shell that fits in the outer part of the inner ear or the inner part of the outer ear, whatever you want to call it. And then, of course, they've got the implantable hearing aids that are implanted, and those are typically only used with some less severe hearing loss, the cochlear implants and those kinds of things. To insert a hearing aid, follow the natural shape of the ear. The hearing aid should fit snugly in without forcing it. If there's a whistle sound, of course, the hearing aid may be inserted a little too far or not far enough to create it may not be inserted far enough to create a seal, or the volume may be up too loud. And it's basically what it's doing is feeding back. Reposition the hearing aid or remove it and turn the volume down. If it still doesn't fit right, after a couple of tries, place it in its case and take it with you to the hospital. Of course, there is always the possibility that you're trying to put it in the wrong ear. A right-eared hearing aid won't fit in the left ear right. Document the transport and transfer of the hearing aids, because those doggone things are very expensive. It might surprise you to learn that they can be upwards of $4,000 or $5,000 a piece. So that's not the kind of thing that you want to have to replace, or you want your employer to replace because you didn't handle them correctly. Don't try to clean a hearing aid or get them wet or anything like that. You don't want to risk damaging it. That's just outside of our wheelhouse for doing that. To troubleshoot it, make sure it's turned on. And of course, it may need a fresh battery, or maybe so many of them now don't take batteries, and when you drop them in their case, they start recharging. Of course, make sure the tubing isn't twisted or bent or it's got a bad kink in it. If it does, it's not that you can fix it. You may not be able to fix it. It may just need serviced. It may need some work. It may need to go back to the hearing aid shop to get fixed. Check that the switch is set to M for microphone. Of course, that may be very dependent on hearing aid, the hearing aid type of style of hearing aid that it is. If it's a body hearing aid, try using a spare cord. There's some of them that used, the old style hearing aids were literally kind of like earbuds. They put them in and you'd have a little box thing about the size of a deck of cards, maybe a little smaller, you'd wear in a front pocket, and that was the hearing aid. That's how you would hear. And make sure that the ear mold isn't blocked with wax. Sometimes those things get easily plugged up with wax, and maybe that's why they can't hear. The newer ones, the more expensive ones are Bluetoothed. So they Bluetooth to their phone, and they hear people talking in their ears and all that kind of thing. So the newer ones are pretty fancy and pretty amazing. So, all right, so there's part 2. We will be back with part 3, the last and final section of chapter 46, and we'll round out 46. See you then.